Hi guys. So I hope I'm live. Give me a thumbs up if you're able to see me live, loud and clear. And once I'm sure that you're able to hear me out, we'll start with the session. First half an hour we'll try to cover some more important quick topics from neurology, and then after that we will start with the cardiology topics. Okay. So first topic that we're going to do today is going to be Parkinson disease. Okay. Now what is Parkinson disease? This is a neurodegenerative disease, right? Now this is the second most common neurodegenerative disease, and there is a common misconception that Parkinson disease is equal to degeneration of substantia nigra, which is not the case. The degeneration first starts in the anterior olfactory area, and that makes anosmia as the earliest symptom of Parkinson disease, right? Then the second site of degeneration is locus coeruleus, which is concerned with regulation of the autonomic functions, and this can lead to, in terms of symptoms, as resting tachycardia and constipation. If you remember, I had told you in the offline classes that many of my Parkinson disease patients are not happy with me because I am not able to solve their constipation problem, right? Okay. Then after the degeneration has happened in anterior olfactory area and the locus coeruleus, then it involves the substantia nigra. And when substantia nigra gets involved, substantia nigra is part of basal ganglia, right? So being part of basal ganglia, it is concerned with the regulation of movement. It is a part of extrapyramidal system, and extrapyramidal system is concerned with regulation of movement, and we lose that regulation, and that results in motor symptoms, right? Now within motor symptom, there are three cardinal motor symptoms. We call them as three cardinal symptoms of Parkinson disease, of PD, cardinal symptoms of PD, right? One of them is tremor, the second one of them is bradykinesia, and the third one is rigidity. Bradykinesia and rigidity. Now among these, if they ask you which one is the earliest to start, then it is going to be tremor. Tremor will be noticed first, and with the progression of time, patients will start showing up bradykinesia and rigidity. And we have to also remember that in Parkinson disease, degeneration doesn't stop at substantia nigra. It can also progress to involve frontal and temporal lobes, and that can lead to dementia, because temporal lobe is concerned with memory, as we know, and frontal lobe is concerned with personality and behavior. Especially there is an area called as prefrontal cortex, which is concerned with the personality and behavior. So in terms of sequence of events, first anosmia, followed by autonomic symptoms, followed by motor symptoms. Within motor symptoms, tremor is the earliest symptom, and eventually dementia. Okay. Now why there is degeneration happening? Because of the accumulation of alpha-synuclein in the neurons. The body is unable to clear alpha-synucleins, and thus the neurons die. And these accumulations can be seen under the microscope as Lewy bodies. Right? So where do we see Lewy bodies? We see them in Parkinson's disease. Now what are the risk factors for Parkinson disease? The most important risk factor for Parkinson disease is going to be age, because most of the patients, when they are diagnosed, they are more than 70 years of age. They are not under 70 years when they are diagnosed on an average. Apart from age, genetics also plays an important role in causing the Parkinson disease, and you have to remember only one important mutation here, which is Parkin1 mutation. There are n number of Parkin mutations, 1, 2, 3, 4. You have to remember only Parkin1. Then inside the biochemistry, you might have studied about apolipoproteins concerned with the lipid metabolism, and one of them is ApoE. And if a particular person carries a variant of ApoE known as E4, that too both the alleles are E4, such patients also carry very high risk of Parkinson disease. This is also an important MCQ point, and this is also an important MCQ point. In terms of other causes, aluminium and manganese toxicity can also cause. Particularly, I want you to remember aluminium toxicity, because aluminium toxicity is becoming an increasingly important cause for neurodegenerative disorders, because we all consume food cooked in aluminium vessels. And I think I had also told you that coffee is protective, and that's why generally in my classes the tea breaks are called as coffee breaks, because coffee protects against development of neurodegenerative disorders, including Alzheimer's as well as Parkinson's. Okay. Now in Parkinson disease, what are the symptoms we can expect? The symptoms can be divided into motor symptoms related to substantia nigra degeneration and non-motor symptoms. Among non-motor symptoms, some of us we already know, right? Anosmia is the earliest of all the symptoms. Patients can have constipation and resting tachycardia because of autonomic nervous system dysfunction. Because of degeneration in frontal and temporal lobe, they can have dementia. And then there is one particular abnormal disorder that we see in Parkinson disease, which is called as REM behavioral disorder. As we enter into REM phase of sleep, normally because our tone goes low, we don't enact our dreams. But in patients with Parkinson disease, there is rigidity. So their muscle tone is already high even when they are in sleep. So all the dreams, they start acting out. This is what we call as REM behavioral disorder, which is characteristically associated with Parkinson disease, enacting of dreams. Okay, these are all considered as non-motor symptom. This can be an MCQ. Which of the following is considered as a non-motor symptom of Parkinson disease, or which of the following is not a non-motor symptom of Parkinson disease? That's a kind of question we can anticipate. Now coming to the cardinal symptoms. Cardinal symptoms are nothing but tremor, rigidity, bradykinesia, right? Now the tremor in Parkinson disease is a tremor which is present at rest tremor, which generally decreases on the movement. So at rest it is present, it decreases on the movement. The tremor has relatively low frequency, 4 to 6 hertz. That means 4 to 6 tremor movements per second. On the other hand, there is another rest tremor called as essential tremor. I think I had told you that even I have essential tremors. These tremors are high frequency, 6 to 16 hertz. Tremors in Parkinson disease affect upper limb more than lower limb, which we all know, and typically tremors affect small muscles, so, or in other words, distal muscles of the hand rather than the proximal muscle. An example of a tremor that you can give where proximal muscle involved is the wing beating tremor, which we see in patients with, where do we see wing beating tremor? Remember this point, wing beating tremor is seen in patients with Wilson's disease. Wing beating tremor is seen in patients with Wilson's disease, and that tremor is a classical example for a tremor involving proximal muscles. The shoulder joints are showing the tremor. In Parkinson disease, the small muscles of the hand are showing the tremor, and because it resembles like the rolling of a pill between the index and thumb finger, right? Thumb and index finger. This is called as pill rolling tremor. And we have to also remember that the tremor is always going to be asymmetric, because degeneration starts in one part of the brain and then the other part of the brain is going to get involved. The tremor will not affect both the sides equally. It will affect one side more than the other. Whenever you have a patient with Parkinson-like tremor but equally affecting both the sides, what should come to our mind? We should think of drug-induced Parkinsonism, right? Symmetric tremor should prompt towards drug-induced Parkinsonism. Okay, so that is about tremor. The second one is bradykinesia. Brady means slow, kinesia means movement. So patients of Parkinson disease generally have slowness of movements. Especially the voluntary movements are going to become slow, and in addition to that there is also slowness of those voluntary movements which have a involuntary movements which have voluntary suppression. For example, blinking of eyes, and when we are walking, the swing of arms, they will also become slow. Their arm swing will be very slow. You can easily like you can go to the YouTube and watch Ratan Tata sir walking, and you will notice his arm swing. That is very classical walk of a patient with Parkinson disease. Then the third thing we can notice here is that because of the slowness of movements, they are very slow to react to the environment. So their facial expressions are also very slow to appear on the face, and because of that, an onlooker may not recognize any emotions on their face. So we describe it as mask-like face or hypomemia letters, because it takes longer time for them to write large letters, so their handwriting becomes very small. We call it as micrographia. That is a second cardinal manifestation about bradykinesia. Then another cardinal manifestation is rigidity. Now what is rigidity? Rigidity means increased tone or hypertonia. How is it different from spasticity? In spasticity, there is same level of resistance throughout the range of, in rigidity, there is same level of resistance throughout the range of movement. In spasticity, initially high, later it is less. So that is why spasticity is also called as clasp knife type of rigidity. So here we see rigidity. When you examine, same level of resistance throughout the range of movement. But sometimes this resistance can be superimposed by tremor. So when there is tremor involved, in that case there will be a jerky rigidity, and what do we call it as? If there is a jerky rigidity, we call it as cogwheel type of rigidity, whenever there is rigidity plus tremor. If there is only rigidity, we call it as lead pipe type of rigidity. Both the rigidities can be seen in Parkinson's. Typically in the upper limb, because there is tremor, we see cogwheel rigidity. In the lower limb, generally there is no tremor until and unless in the late course of the illness, so we see lead pipe rigidity. Okay, now this rigidity also affects the center of the body or core body muscles, and here it affects the front muscles more than the back muscles. So front muscles are more contracted, and because of that these patients tend to develop a stooped posture. They bend forward, and when they bend forward they have a tendency to fall forward when they walk, and to escape from falling they start to accelerate as they walk, and this gait is called as festinant gait. So this is also going to be an MCQ. Where do you see festinant gait? We see that in patients with Parkinson disease. The gait is also called as short shuffling gait. Short shuffling gait. Okay. Now one more manifestation of this stooped posture is, if a patient of Parkinson disease, if you ask them to lie down on a bed, their stooped posture or the curvature of the spine disappears, because it is only because of a slight contraction of the anterior muscles. Once they lie down, gravity will eliminate that contraction and their curvature disappears and they become flat, and this is what we call as camptocormia. This is again an extremely important MCQ point. Where do we see? This can be a image based question also. But if a patient has a true spinal cord deformity, whether you are straight or lying down, the curvature will persist, it will not disappear, right? So here is an image which has appeared once in the previous examination. Same image, literally flicked from the internet. You can see there is curvature to the spine, disappears to become a flat line once the patient lies down. What do we call this as? This is called as camptocormia. These are the clinical features. So an elderly patient presenting with tremor, bradykinesia, rigidity, or the other symptoms that we studied, you can suspect Parkinson disease. Now how do we diagnose? Remember, the diagnosis of Parkinson disease will be on clinical grounds, and generally we do not require investigations, right? Now the diagnosis will be based on a criteria called as MDS criteria. Now according to this criteria, we are supposed to have bradykinesia. It's a mandatory symptom. If you have bradykinesia plus between rigidity and tremor, any one of them is present, it is enough to diagnose a case as Parkinson disease. Like if you have bradykinesia plus rigidity, you can call it as Parkinson disease, or if you have bradykinesia plus tremor, you can call it as Parkinson disease. But bradykinesia is must. If you have rigidity and tremor, you cannot call it as Parkinson disease until and unless you have bradykinesia. So they can also ask you as which of them is considered as a mandatory symptom. Mandatory symptom is bradykinesia. So based on MDS criteria, once you have diagnosed the case as Parkinson disease, the next question that will be, how will you manage, right? Management you also study in pharmacology, but before going there, one quick image based question. Imaging is generally not required for Parkinson disease, but still they can ask you questions. And what is that question? When we see substantia nigra in MRI, right? Normal substantia nigra appears to look like the tail of this swallow bird, a bifid appearance, right? This is what we call as swallow tail sign. So normalcy is presence of swallow tail sign. In Parkinson disease, there is death of neurons in substantia nigra. So there will be atrophy of the substantia nigra, and this bifid or two-pronged tail-like appearance will be gone. Once it is gone, it will be called as loss of swallow tail sign, like you see here. There's only one, there are no two prongs to the tail. So this is what we call as loss of swallow tail sign, which is seen in Parkinson disease, and this is highly specific for Parkinson disease. इसकी ज़रूरत नहीं है डायग्नोसिस के लिए, वो अलग बात है, लेकिन this is a specific finding for the Parkinson's disease. Okay, so to give you a quick summary, what MCQs they will ask you on Parkinson disease. First thing they will ask you is, what is the single most important risk factor? Single most important risk factor is age. They will ask you about the mutations, right? Then they will ask you about the cardinal symptoms of Parkinson disease. Cardinal is nothing but tremor plus rigidity plus bradykinesia, or motor symptoms are called as cardinal symptoms. Okay. Then they will ask you generally about the diagnostic criteria, camptocormia as a clinical finding or an image based question. They will ask you about the name of the diagnostic criteria and which of the symptom is considered as mandatory. Okay, this can be an image based question. Now once you have made a diagnosis of a case as Parkinson disease, it comes to the management. Now management, the problem is there is lack of dopamine in the substantia nigra. We want to increase the dopamine in the substantia nigra. We can use various methods to achieve increase in dopamine. One method is that you can block the dopamine degradation. There is an enzyme called monoamine oxidase B, which inhibits, which converts the dopamine to unusable end products. Similarly, there is catechol O-methyl transferase, which degrades dopamine. So we have option of blocking these with drugs like selagelin, rasagelin, or tolcapone, entacapone. Other option is that we can give dopamine agonists like bromocriptine or cabergoline. Other option is we can supply the raw materials for the dopamine synthesis like levodopa, right? Now this levodopa gets converted to dopamine by an enzyme called as dopa decarboxylase. Now among all the drugs I have listed here, they will ask you what is the most effective medication, and that is levodopa. Levodopa is the most effective medication, and that is why as of now, currently in 2023, we don't try to treat the patients with amantadine or other less effective drugs. In any case of Parkinson disease, our first go-to drug will be levodopa, and you might have studied in pharmacology that levodopa comes with side effects. What are the side effects? The side effects of the levodopa are that it causes severe nausea and vomiting. And this nausea and vomiting that I am writing here is not like the nausea and vomiting you routinely write for all drugs. This really causes severe nausea and vomiting, and it is a limiting factor. Many patients don't continue the drug if you give levodopa alone. And second, it can cause hypertension because dopamine is a vasoconstrictor. It can cause hypertension. Now to avoid these side effects, we have to inhibit the conversion of levodopa to dopamine in the periphery. We want levodopa to reach all in the substantia nigra and become dopamine there. Now how do we achieve that? We use drugs called as peripheral dopa decarboxylase inhibitors, and examples for this is carbidopa and benserazide. Between these two drugs, carbidopa is more effective. So whenever we give levodopa, we should be giving carbidopa also. So the 2023 guidelines recommend that for all patients of Parkinson disease, we should start them on levodopa and carbidopa. No longer role of any other drugs as an initial choice. You might have studied different things in pharmacology, but clinical medicine is slightly different. This will be the starting medication. The dose you can up titrate or down titrate depending on the symptoms. And for all patients, now we also tend to give rasagelin. Why we give rasagelin? Because rasagelin has neuroprotective properties. It has neuroprotective properties. It can protect the dying neurons. So that's why we also add rasagelin. So these three drugs are the initial combination of medication. If patient is not responding to these medications, you have the choice of giving them monoamine oxidase B inhibitor, or you can also think of COMT inhibitors as the second line agents. Now in those patients who are refractory to medications, you're not able to control their symptoms with medications, we can do a procedure called as deep brain stimulation or DBS, where we put an electrode into the brain and continuously keep stimulating it. Okay. Now last but not the least, there is an important update. There's a new drug called as istradefylline, which is used for the mitigation of off phenomenon. Now today I am not going into the details of on and off phenomenon. Those who are not familiar with it, you can ping me. I'll share some clips about the on and off phenomenon. But when we treat Parkinson disease, at times when the drug level is optimum in blood, patients are symptom free, but when drug levels drop, their symptoms bounce back. This is what we call as off phenomenon. To take care of that, we have a new drug called as istradefylline, which is recently approved, right? So you should be aware about this drug. This is going to be an important MCQ point. Okay, now moving on to another neurodegenerative disease, that is Alzheimer's disease. Just like Parkinson disease, here also there is neurodegeneration, degeneration of cholinergic neurons, mainly starting in the temporal lobe and then parietal lobe, eventually frontal lobe. The least affected lobe, that is also going to be an MCQ. The least affected lobe will be occipital lobe. Occipital lobe is generally not affected in patients with Alzheimer's disease. Until and unless patients really survives long with Alzheimer's disease, this will not be affected. Shumayal, we will run a series of such sessions for another 5 or 6 sessions, and I'll try to cover the other important systems also. The other important systems, because many students have not attended my offline classes, I'll try to go a bit slow. Okay. Now, why there is degeneration in Alzheimer's disease? It is because of the accumulation of beta amyloid and tau proteins, right? Body can't clear these proteins, so it will clear the neurons. And because temporal lobe is the earliest site of degeneration, earliest symptom will be memory deficit. And memory, whenever it is lost, we lose the short term or a recent memory first, and then eventually long term memory will be affected. So patients tend to forget where are they, what did they eat few minutes back, or whom they met in the morning, but they will remember their past events very well. Okay, so any patient, especially elderly, presenting with memory deficits, you can think of a possibility of Alzheimer's disease, but before you label them as Alzheimer's disease, you need to rule out reversible causes of dementia. So Alzheimer's disease is also diagnosed on clinical grounds after ruling out reversible causes of dementia. Now, what are the reversible causes of dementia? There is a long list of reversible causes for dementia. I have listed important ones, like you know about this 𝐒𝐿𝐂𝐿 syndrome due to thiamine deficiency, very common in alcoholics, right? In there, one of the symptoms is confabulation. Confabulation is because they have the memory deficits, so they try to fill the memory deficits by made up stories. Then hypothyroidism, vitamin B12 deficiency, right? Pellagra, you remember it with 3 Ds, and one of the Ds of pellagra is indeed dementia. And last but not the least, vitamin E and selenium deficiency. These all are called as reversible causes for dementia. So rule them out before you come to the diagnosis of Alzheimer's disease. So the minimum investigation that we would need is a TSH and a vitamin profile. If they turn out to be normal, then you can think that the patient is having Alzheimer's disease. Now, when it comes to the management of Alzheimer's disease, we have to think of 2 approaches. One, can we do something to protect the dying neurons? Yes, we have some new drugs in pipeline. One of the drug is called as aducanumab, and the second drug is called as lecanemab. Particularly, I want you to remember lecanemab because this is recently approved. In 2023, it is approved, and it is basically a monoclonal antibody against beta amyloid. As we know, Alzheimer's disease is due to accumulation of beta amyloid and tau proteins. So by giving monoclonal antibodies which can inhibit the beta amyloid accumulation, you can slow down the death of neurons. 2 drugs here, aducanumab and lecanemab. These will slow down the progression, and to control the symptoms, right, we need to basically increase the acetylcholine, which we can achieve with the acetylcholine esterase inhibitors. The commonly used drugs are donepezil and rivastigmine. We have another drug called as galantamine, which is an NMDA blocker. And there was one more drug called as tacrine. The drug is not important but from pharmacology side, they repeatedly asked this MCQ, why this drug was taken off market. The drug was taken off market because of the risk of liver injury or hepatotoxicity, right? So this is about the Alzheimer's disease. The next quick topic is your motor neuron diseases. Yesterday we have studied about what is a motor neuron. Motor neuron is primarily a neuron which is concerned with the transfer of information from brain to the muscle for the contraction of muscle or voluntary movement. Now the motor neurons are primarily of 2 types. One from cortex to spinal cord is called as upper motor neuron, and in the spinal cord we have anterior horn cell. From anterior horn cell to the neuromuscular junction is called as lower motor neuron. So if there is any disease which only affects the motor neurons, not an anatomical structure entirety, not the entire spinal cord, not the entire brainstem, not the entire cortex, not the entire peripheral nerve, selectively damaging the motor neurons, they are called as motor neuron diseases. Now, one of the MCQ you can expect on motor neuron diseases is which of the following is a pure UMN type of motor neuron disease, or which of the following is a pure LMN type of motor neuron disease, or which of the following is both LMN plus UMN type of motor neuron disease. And for that you need to remember this classification table. It is pretty damn easy and it's all logical. Okay, so pure UMN you have examples like primary lateral sclerosis, logically rememberable because lateral sclerosis, the lateral word here primarily means lateral corticospinal tract, which is nothing but your pyramidal tract. So pyramidal tract obviously contains, pyramidal tract is there from the brain to spinal cord, so it obviously contains upper motor neurons. It contains upper motor neurons. Okay, and this example anyway we can remember from PSM. There is something called as neuroletharism or latherism, which is due to toxin called as beta-oxalylalanine amine. Here patients develop spastic paraparesis, and when you say spastic, spasticity is a sign of upper motor neuron damage. Okay, in terms of pure lower motor neuron diseases, there are two examples. One is progressive muscular atrophy, and yesterday also we learned that atrophy is a hallmark of lower motor neuron damage, right? So when you say atrophy is there, it already points towards lower motor neuron being involved. Okay, then there is a second condition called as spinal muscular atrophy. Spinal muscular atrophy is an inherited motor neuron disease due to mutation in a gene called as SMN1. Some of you may be able to remember that I had told that there is a drug which is so damn expensive, literally costing 16 crore rupees, a genetic therapy which is available for this disease, spinal muscular atrophy. Right, again here we are talking about atrophy. The moment you see atrophy in a question, right, and it is about motor neuron diseases, it has to be lower motor neuron. Okay, and this spinal muscular atrophy, we have some treatment. So one of the drug is a gene modulator like nusinersen, and then we have a gene therapy, onasemnogene abeparvovec, which costs 16 crores. So as of now, the costliest treatment is available for this disease, spinal muscular atrophy. Okay, and then the last example for a pure LMN is poliomyelitis. Anytime you see a patient with polio, you remember seeing them with very atrophic limbs, right? Atrophy is equal to LMN. And then we have one condition where both UMN and LMN is involved, and that is amyotrophic lateral sclerosis, the disease that which the Stephen Hawking was suffering from, amyotrophic lateral sclerosis. It is an example for a mixed. Again, it is there in the name. Amyotrophy, it is talking about atrophy. Lateral, it is talking about the pyramidal tract. So both UMN as well as LMN involvement. Okay. Now we will focus on few points about the amyotrophic lateral sclerosis. Just like Parkinson's disease and Alzheimer's disease, it is also a neurodegenerative disorder, and here it is due to accumulation of a substance known as ubiquitin immunoreactive protein. Parkinson's disease was due to accumulation of alpha-synuclein, right? Alzheimer's disease was due to beta amyloid and tau proteins, and this ALS is due to ubiquitin immunoreactive proteins. Okay, so in this condition both there is UMN and LMN damage, and in terms of the clinical features, these patients generally present with weakness of muscles because there is a motor neuron involved. Second and most important and a characteristic finding is they can develop either bulbar or pseudobulbar palsy. Now this is again an important MCQ template, so let me spend 3-4 minutes trying to explain what is bulbar or pseudobulbar. Okay, now you have to remember that the moment I say bulb in the neurology, it means your medulla, right? And yesterday I told you that the cranial nerve nuclei are there in the brainstem. There are 4 above the pons, 4 at pons, 4 below the pons. Among the 4 above the pons, 1 and 2 have nothing to do with brainstem, so 3 and 4 are there in the midbrain. 5, 6, 7, 8 are there in the pons. 9, 10, 11, 12 are there in the midbrain, right? In the medulla. And this medulla is what is called as bulb. Okay, but we have to remember that even the medulla is under the influence of the cortex, because brainstem they not directly act. Cortex gives them the information and medulla responds to that, right? So cortical neurons from the motor cortex which reach the cranial nerve nuclei, they are called as upper motor neuron. From cortex to the cranial nerve nuclei, this will be considered as an upper motor neuron, and there are cranial nuclei in the brainstem. From there, whatever cranial nerve that is coming out, that will be considered as lower motor neuron. So if there is a damage at the level of bulb, that means your medulla, that is primarily causing the lower motor neuron damage. And if there is a damage above the level of brainstem, but that is resulting in cranial nerve dysfunction, that is upper motor neuron damage. So at the level of the medulla damage is lower motor neuron damage, above that it is upper motor neuron damage, right? So when the damage is at the level of medulla is equal to bulb, so we call it as bulbar palsy. So bulbar palsy is characteristically element type. And when the problem is above the medulla, means here is our medulla, its cranial nerve nuclei are not affected, but the cortex to medulla tract, there is a damage. Then it will be called as pseudo-bulbar palsy, because the problem is not in the bulb, problem is somewhere else. That's why we call it as pseudo-bulbar. In that case, there is damage to upper motor neurons coming to the cranial nerve nuclei. Now, how will we get to know that patient whether he has got bulbar or pseudo-bulbar palsy? The characteristic symptoms of whether it is bulbar or pseudo-bulbar, the patients will develop 3 Ds. What are those 3 Ds? Dysarthria, dysphonia, dysphagia. Why these 3 Ds? Dysarthria, dysphonia, dysphagia. The reason for that is because cranial nerves 9, 10, 11, 12 are important for speaking and swallowing, right? All that is happening in your neck, speaking and swallowing. For example, recurrent laryngeal nerve, which is branch of the vagus nerve, is supplying the larynx and it is responsible for speech, right? Swallowing is a function of 9th and 10th cranial nerves. Tongue movement is a function of the hypoglossal nerve. So all of them, if they are damaged, you will have difficulty in speaking, difficulty in swallowing. So these 3 Ds suggest that there is a problem in the medullary cranial nerves. Okay, if the problem is exactly in the medulla, it is called as bulbar. If it is above the medulla, we call it as pseudo-bulbar. How to differentiate between these two? The best bet is to look at the reflexes. When LMN damage, reflexes go down. When UMN damage, reflexes go up, right? So the 2 reflexes which are mediated by cranial nerves are gag reflex and jaw jerk. The gag and the jaw jerk will be diminished in case of bulbar because it is LMN palsy, and they will be exaggerated in case of pseudo-bulbar because it is UMN palsy. Clear? Okay. So now in amyotrophic lateral sclerosis, they have this bulbar or pseudo-bulbar palsy plus weakness of other muscles because of motor neuron death. Now, how we diagnose them clinically? For clinical diagnosis, we have a criteria called as L-Escorial criteria. I have already told you one criteria for Parkinson disease, that is your Movement Disorder Society criteria. For Parkinson disease, that was the criteria. For the amyotrophic lateral sclerosis, L-Escorial criteria. In this criteria, we divide the body into 5 regions. I am not getting into the details for now. Among these 5 regions, if 3 or more than 3 regions show the UMN and LMN findings together, then we make a clinical diagnosis of amyotrophic lateral sclerosis. All you need to remember here is the name of the criteria and how many regions should show LMN plus UMN involvement, and that is 3 or more than 3 regions. If you remember, that's kind of more than enough. Okay. Now finally coming to the management of amyotrophic lateral sclerosis, this is one of the really terrible disease. Most of the patients will not be able to survive for more than 3 years after the diagnosis. The best outcome is possible when we give them good supportive care, but there are 2 drugs available. One of them is riluzole and the other one is edaravone. Riluzole and edaravone, both of them increase the life expectancy by around 3 months. But I might not have covered this in some of the classes because the update is very recent. So there is a new drug which has been approved just a couple of weeks back or maybe a month back. New drug which is called as tofersen. This is going to be a potential MCQ point. Tofersen. Tofersen is the modulator of superoxide dismutase. Superoxide dismutase 1 gene, which has been believed to play a role in the pathogenesis of amyotrophic lateral sclerosis. This is going to be a potentially important MCQ point for your upcoming FMGE exam because it's a very new drug, right? So in Parkinson disease, I told you to remember one drug called as istradefylline, which is again a new drug. Istradefylline. Istradefylline, which is very new and it's important for the upcoming examination, and so is your new drug called as tofersen. Tofersen for amyotrophic lateral sclerosis. Okay, now the last topic that I'm going to address in case of the neuro is going to be your demyelinating disorders of the CNS. Extremely important. Mostly you can anticipate questions asking you to differentiate between multiple sclerosis, neuromyelitis optica, and myelin oligodendrocyte glycoprotein disorders, right? These three are examples where there is demyelination of the central nervous system. Okay, so first I will address multiple sclerosis. The name here, multiple, is usually used because multiple here means multiple episodes of demyelination affecting multiple sites in the nervous system. That's why we use the term multiple. Episodes of demyelination affecting multiple anatomical lesions multiple times. One MCQ that they will ask you is what is the most common site of demyelination, and the most common site of demyelination is going to be spinal cord. And in the spinal cord we have ascending and descending tracts and the central gray matter. Can the gray matter be demyelinated? No, because gray matter contains cell bodies. Cell bodies are not having myelin. So where demyelination can happen, particularly tracts where the axons are running, either it has to be ascending tracts or descending tracts, and the most commonly affected tract is going to be the sensory tract. So if they ask you what is the most common symptom of multiple sclerosis, you should say loss of sensations, because sensory tracts are the ones which are most commonly vulnerable. And the second most commonly affected site is optic nerve. Now here is one important point. The optic nerve, or when optic nerve gets affected by demyelination, right, we call it as optic neuritis. And optic neuritis can be divided into anterior optic neuritis and posterior optic neuritis. Now what is the difference between anterior and posterior optic neuritis? So when you look at the eye structure, right, so you have a cornea, lens, and you have retina, and in the retina you have an optic disc to which the optic nerve gets attached. So this is your optic disc. When I say anterior optic neuritis, it means the problem is starting with the disc and involving some distance of the optic nerve. Demyelination is affecting disc as well as some part of the optic nerve. And when you say posterior, that means disc is not affected. Only the course of the optic nerve behind the eyeball is affected. In that case, we call it as posterior optic neuritis. Now, how do I differentiate? All I need to do is look through the fundus and see whether optic disc is showing edema or not. If optic disc is showing edema, that means it is affected. In that case, it is anterior optic neuritis. If optic disc doesn't show edema, that means optic disc is not affected. That means it is not anterior. When you do an MRI, if you see demyelinating changes in the retrobulbar course of the optic nerve, then it is a classical case of posterior optic neuritis. In case of multiple sclerosis, it is generally unilateral and it is going to be anterior. So patient will present with one-sided loss of vision, and when you look through the fundus, you will see that the disc is edematous in case of multiple sclerosis. In case of neuromyelitis optica, it will be posterior, and there you will not be able to see the disc edema. The demyelination can also affect cerebellum, subcortical structures, as well as brainstem. Okay. Now, if a patient presents with like features involving the sensory deficits or optic neuritis, or because of the cerebellar demyelination, if they have ataxia, you can suspect the possibility of the multiple sclerosis. Now, for diagnosis, we might have to think of doing an imaging, and imaging primarily should focus on MRI. CT scan is not a good investigation for recognition of the demyelination. And in the MRI, we will be able to see the demyelination as oval, white, or hyper intense signal changes. And these oval signal changes, they will be often distributed as finger-like projections coming out from the ventricle. Remember, this black fluid filled structure is your ventricle, and above that you have corpus callosum. And in the corpus callosum, remember, corpus callosum is what? It is a tract connecting a right and left cerebral hemispheres. So basically it is tracts. Tracts contain axons, they contain myelin, so it is white matter, and there is demyelination, and these demyelinating plaques look like finger-like projections, and we call these finger-like projections as Dawson's fingers, right? Dawson's fingers is a repeatedly asked MCQ. Where do you see that? And identification of that in the exam, in the images. Both are important points. As I've already told you, demyelination can also affect, in fact, spinal cord is the most common site. Remember, when demyelination affects the spinal cord, in case of multiple sclerosis, it involves less than 3 segments of the spinal cord, less than 3 segments. Now, what do I mean by segment? One vertebral column is equal to one segment. Like this is one vertebral column, so this will be considered as one segment. Like for example, let me say this is C1 segment, this is C2 segment, this is C3 segment. In case of multiple sclerosis, the involvement will be of less than 3 segment. In case of neuromyelitis optica, the involvement will be long, more than 3 segment. That is a second important point to differentiate. First point is optic neuritis in case of multiple sclerosis is unilateral and anterior. In case of the neuromyelitis optica, it is bilateral and posterior. And in spinal cord involvement in multiple sclerosis, less than 3 segments. In neuromyelitis optica, more than 3 segments. Okay. Now, this imaging only tells you that there is demyelination, but to call it as multiple sclerosis, we need to prove that there are multiple episodes of demyelination affecting multiple anatomical sites. And we have given a name for this criteria called as McDonald's criteria, right? McDonald's criteria. MDS for Parkinson disease, L. escorial for amyotrophic lateral sclerosis, McDonald's for the multiple sclerosis. Okay. At this point of time, I'm not getting into the details of how to apply this McDonald's criteria because that will be a very high level question. Unlikely that it will be asked for you, but at least remember what is McDonald's criteria. Where is it applied? It is for the multiple sclerosis. Okay. Now, other than that, we have to also remember that there is something that we can see on the CSF, especially when we do the CSF protein electrophoresis. When we do protein electrophoresis, proteins, depending on the charge on them and the molecular weight, on the electrophoresis, they will be precipitated as bands at different locations. Normally, CSF is not supposed to have IgG, so there will be no IgG band. But in case of multiple sclerosis, demyelination is carried by the IgG molecules. So you will have a band appearing in the IgG range of the electrophoresis, and this is what we call as oligoclonal bands. Another MCQ, where do you see oligoclonal bands? First answer should be multiple sclerosis. Okay. Now here is a small table trying to compare between the multiple sclerosis, neuromyelitic optica and MOG disorders. We will start the cardiac revision by 9 o'clock. Okay. So in multiple sclerosis, the antibody that is responsible for demyelination is called as anti-myelin basic protein antibody. The antibody that we see in neuromyelitis optica is called as anti-aquaporin 4 antibodies. And in the MOG disorder, name itself says myelin oligodendrocyte glycoprotein. That is where the MOG comes from. That antibody we see. Okay. Now, clinically, how to differentiate? Because we can't keep testing the antibodies in all cases. So, clinically, all we need to do is look at the involvement of the optic nerve and the spinal cord. The optic nerve in the multiple sclerosis is generally unilateral optic neuritis, and that too anterior. So, when it is anterior, we can clearly see as disc edema or papilledema. Disc edema will be present. Okay. In neuromyelitis optica, it is usually bilateral. It can be rarely unilateral. Most commonly, it is going to be bilateral and it is posterior. So, when you see through the fundus examination, nothing you see. When you do an MRI, optic nerve will show demyelinating changes. And in case of MOG disorder, the optic neuritis is anterior, just like your multiple sclerosis, but not unilateral. It will be bilateral. So this is one parameter that will easily help you to differentiate between these three disorders. If patient has unilateral optic neuritis anterior, it is multiple sclerosis. If he has bilateral anterior optic neuritis, it is MOG disorder. If it is bilateral but posterior optic neuritis, it is neuromyelitis optica. And the next point is that the involvement of spinal cord. In case of the MOG as well as multiple sclerosis, there will be less than 3 segment involvement. But in case of neuromyelitis optica, there will be more than 3 segment involvement. And last but not the least, in terms of prognosis, neuromyelitis optica carries the worst prognosis, MOG disorder carries the best, and multiple sclerosis overall has the moderate prognosis. Okay. Now this table I want you to memorize even for your mock as well as for your main exam, because you can anticipate one question for sure. Like in recent last 2 or 3 NEET, PG, INI, CET exams, there is one question asking you to differentiate FMG. It is certainly anticipated. Okay. Now last point is about the management of multiple sclerosis. Now here we have to remember that before we manage the cases, we have to classify after the diagnosis the case into 3 types: relapsing and remitting type, secondary progressive, and primary progressive. Okay. Now how we are classifying it? Based on the disability. After every episode, whether patient comes back to normalcy or stays disabled. In relapsing and remitting, after every episode, disability increases but they come back to normalcy. And because they come back to normalcy, their prognosis is generally good. They have a very good prognosis. They will have multiple episodes of demyelination, but every time they will recover. And this is the most common type also. In the secondary progressive, initially it behaves like relapsing and remitting. After every episode of demyelination, patient becomes disabled, but he will make a near total or good recovery. But somewhere down the line, they fail to recover and new episodes of demyelination keep adding up on the disability. This is what we call as secondary progressive. And in the primary progressive type, every episode of demyelination keeps making them more and more disabled. They don't come back to normalcy at all. We call this as primary progressive. Now, why this is important? 2 kinds of questions you can expect. You may get questions where they give the image and they will ask you which type of multiple sclerosis it is, right? If you see after every jump in disability, if it is coming back to baseline, it is relapsing and remitting. If initially coming back to baseline, but after that it starts increasing in terms of disability, this is secondary progressive. Right from the beginning, if the disability keeps increasing, it is primary progressive. Now the second reason we need to know is when it comes to management, right, they will ask you which of the following is a newly approved drug for primary progressive type, right? I will come to that point. Any case of multiple sclerosis, when there is an acute diagnosis, initially for 3 to 5 days, we treat them with high dose steroids so that we ensure that they recover from the episode of demyelination. But it is multiple sclerosis. They will have multiple episodes of demyelination. To prevent future episodes of demyelination, we put them on immunomodulating drugs. Okay. Now only one point I will emphasize here. There is a new drug called as 𝐒𝐿, which is a monoclonal antibody against CD20. CD20 is a marker of lymphocytes, right? Particularly B lymphocyte. It's a B lymphocyte marker. B lymphocyte is the one which produces the antibody. So this monoclonal antibody will inhibit the B lymphocytes. They will not be able to produce the antibody, so no damage to the myelin sheath. This is a newly approved drug for primary progressive. Otherwise, till 2021, we did not have any drug for prevention of primary progressive multiple sclerosis. We had a lot of other drugs, not so important for the exam, for prevention of secondary progressive and relapsing and remitting, but primary we didn't have, and now we have a drug. What is the name of the drug? 𝐒𝐿 or 𝐒𝐿. Please remember, this is going to be a potential MCQ point. Okay, so that's about our multiple sclerosis. Okay, now we will quickly move to the cardiology, right? Yesterday I have also covered about the stroke, so we'll start with the cardiology. Now I know most of you have a fear about the valvular heart disease in cardiology. I would ensure that you don't need to worry about valvular heart disease. Tomorrow on the Telegram, I will put a small table about all the 8 valvular heart diseases. What are the murmurs? Which phase of cardiac cycle those murmurs are heard? What additional important points you need to remember? So just memorize that table and you should be good to answer most of the questions coming from valvular heart disease. So we will not waste our energy or time behind valvular heart disease, rather concentrate on other important topics from cardiology. Okay, so we'll start with a quick take on the ECGs. Now in the ECG, basic thing is all known to us. We have P, Q, R, S, T waves. P wave is due to atrial depolarization, QRS is due to ventricular depolarization, and T wave is due to ventricular repolarization, right? So if I have to look at any atrial abnormality, I should be looking at the U wave. Sakshi, I will share the link at the end of the session. Okay, so we should be looking at the P waves whenever you are thinking of the atrial abnormalities, right? Now what abnormalities of the P wave we can see? If there is right atrial enlargement, the P wave becomes very tall. The normal size of the P wave on the ECG should be in terms of width less than 2.5 small squares, in terms of height less than 2.5 small square. Now remember here, one small square on a normal ECG in terms of height represents 0.1 millivolt, right? And one small square in terms of width represents 40 milliseconds, right? So in terms of the P wave duration, it should be less than 100 milliseconds, less than 2.5 small squares in terms of horizontal width and less than 2.5 small square in terms of height or amplitude. Whenever height is more than 2.5 small squares, we call it as P pulmonale, tall P waves, and tall P waves indicate right atrial enlargement, right? Like you can see in this ECG. And remember always, the best lead to look for P waves is lead 2 and V1. First choice should be lead 2. And then if you want, you can look at the lead V1 also. So in this case, when you look at the lead 2, you can notice that this P wave, particular this P wave, right? It's quite taller than two small squares. It is almost like one large square, right? This is one small square, this is two small square, 3, 4, almost like a large square. When it is more than 2.5 small squares in terms of width, in terms of height, we call it as P pulmonale. P pulmonale indicates right atrial enlargement. Similarly, if there is left atrial enlargement, then we will see biphasic P waves. Instead of looking at one P wave, we will see two P waves. We call it as biphasic P waves. Whenever we have left atrial enlargement, we will have bifid P waves or biphasic P waves, which is also called as P mitral, like you see in this image. The P wave has two waveforms. This is what we call as P mitral. P mitral is seen in left atrial enlargement. Right atrial enlargement, tall P waves. Left atrial enlargement, bifid P waves. Right atrial enlargement, P pulmonale. Left atrial enlargement, P mitral. Okay, if you get confused which one is called pulmonale and which one is called mitral, easy to remember. When it is bifid, you can remember M, right? Bifid is mitral, M for mitral. Okay, so first abnormalities of P wave. Tall P wave indicates right atrial enlargement, bifid P wave indicates left atrial enlargement. Now in the ECG, after P wave, we have this PR interval. If you remember clearly, I have told you in the ECG, interval is equal to inclusion of a wave within it, and when you say segment, there will be no wave inside it, right? So this area will be called as PR segment, this area will be called as ST segment, and this will be called as TP segment. Within this there is no wave, but when you include P wave into it, this will be PR segment, right? When you include this whole thing, this will be called as QT segment. So segments, QT interval. So intervals always include a wave in it and segments do not include a wave. So in terms of interval can become short or interval can become wide. In terms of segment can get elevated or segment can get depressed. Right. So we'll first talk about the PR interval. PR interval starts from the beginning of P wave and ends with the beginning of QRS complexes. This is what we call as PR interval. And the baseline between P wave and the QRS, this will be called as PR segment. Segment, no waves. Interval includes a wave. The normal PR interval is 120 to 200 milliseconds. I have already told you one small square is equal to 40 milliseconds. So in that case, 120 to 200 millisecond means you are supposed to have 3 to 5 small squares. When there are 3 to 5 small squares between the beginning of P waves and the beginning of the QRS complexes, then it is normal. But if it is less than 3 small squares, it is abnormal. You can say short PR interval, and when more than 5 small square, again it is abnormal. We can say wide PR interval. Right. Short PR interval, there are many conditions, but only one condition I want you to remember, and that is nothing but your WPW syndrome, right? So in WPW syndrome, you have a accessory conducting pathway called as bundle of Kent, and because of that, there is a faster conduction of the impulse from the SA node to the ventricle. It will be bypassing the AV node and reaching to the ventricle in a faster fashion. That is why the PR interval will be very short, right? Now, how to identify WPW syndrome on the ECG? That's the question, right? How to identify? There are three findings that will help you to identify. Number one, short PR interval. Normal PR interval is 3 to 5 small square, 120 to 200 milliseconds. But in WPW syndrome, it will be less than 3 small square. That's the first finding. Okay. Like you can notice here, this is the P wave and this is the beginning of the QRS complex. The interval is only 1-2 small squares, not more than that. So that means it is short. Second finding we will see is when you look at normal QRS complexes, after the P wave, you may have a Q wave and then R wave has a direct straight ascent. But here what you see, it has a slight slant and then it starts ascending up. This slant is what you call as delta wave. Delta wave. Okay. The third finding you might notice is that the QR interval, QRS, this QRS complexes, they will be wider. When you have these three findings, you can say it is a case of WPW syndrome. Now, why is it important for us to recognize the WPW syndrome? Because WPW syndrome patients are prone for arrhythmias originating above the ventricle, like SVT, which you also call it as PSVT, and atrial fibrillation. These two arrhythmias are very common in patients with WPW syndrome, right? So before we move on, again a quick recap of the ECG findings. Short PR interval, that means less than 3 small squares. Slanted R wave upstroke called as delta wave, and wide QRS complexes, right? These are the findings we see in WPW syndrome. That is about short PR interval. Now, in what condition we see prolonged PR interval? That means PR interval more than 5 small squares or more than 200 milliseconds. Typically, we see that in patients with the AV blocks, right? And we all know AV blocks is a repeatedly asked question. Even in NEET PG, INI CT, NEET SS, everywhere, almost every alternate exam, there will be one question about the AV blocks, right? Now, AV blocks are divided into 3 types: the first degree, second degree, and third degree. So, in the first degree AV block, all we see is there is a prolongation of PR interval. Normal PR interval is 120 to 200. When it is more than 200, we call it as prolonged. So there will be prolonged PR interval, but every P will be followed by a QRS. There will be no absent QRS. Then we will call it as first degree AV block, like you can see in this image. What do you notice in this image? There is a P followed by a QRS. There is a P followed by a QRS. There is a P followed by a QRS. There is no missed QRS. Okay, then how do I get to know it is a first degree AV block? Look at the PR interval. What is the PR interval here? PR interval starts from here till here. Now, when you look at this, normal PR interval should be less than 5 small square. More than 120 and less than 200 milliseconds means 3 to 5 small square. Here, 5 small squares are done here itself. Additionally, there are 4 more small squares. So, there are like 9 small squares, which is equal to 360 milliseconds. 1 small square is equal to 40 milliseconds. So clearly there is prolonged PR interval without any missed QRSs. That is what is our first degree AV block. Now the second degree AV blocks are further divided into 2 types. Mobitz type 1, which is also called as 𝐌𝐞𝐝 phenomenon, and Mobitz type 2. Okay. Now in Mobitz type 1, the PR interval keeps prolonging with every beat. This beat to next beat, the PR interval will be bigger. The next beat, it will be even bigger. This prolongation will continue till one QRS disappears, right? That is your Mobitz type 1. In Mobitz type 2, intermittently QRSs disappear, but the PR interval remains constant. That is your Mobitz type 2. Most of the times questions are asked about differentiating between type 1 Mobitz and type 2 Mobitz. So you have to remember these well. Okay. So here is one image where you can see that PR interval is progressively increasing. So here it is 5 small square, here it is 6 small square, it becomes 7 small square. So it is progressively increasing, and then we had a P wave which did not culminate in a QRS. There is a missed QRS. Serially increasing PR interval with a missed QRS is Mobitz type 1, also called as 𝐻𝐶𝐝 phenomenon. And then we have a second degree AV block, Mobis type 2, where the PR interval is constant. When you look at this ECG, you can notice that everywhere it is same. It is not increasing progressively, but yet you have a missed QRS. This is what we call as Mobis type 2 second degree AV block. And then we have a third degree AV block. Third degree AV block is generally called as AV dissociation. That means atria and ventricle are not related. P waves are appearing randomly, QRS complex are appearing randomly. Once you see that the relation between the P waves and QRS is lost, we call it as third degree AV block. Like you can see in this ECG, there is a P wave which is after QRS, then there is a P wave after a T wave, and there is a P wave before a QRS. This is what we call as AV dissociation. Normally what happens in a ECG, P is followed by the QRS, right? Again, next P followed by QRS complex. So there is a relationship. That relationship is lost, then we call it as third degree AV block. This year I am expecting a question primarily between your Mobis type 1 and Mobis type 2. So please remember, type 1 serial prolongation till the missed QRS, type 2 constant PR and the missed QRS. Okay. So far I have told you about P waves. P wave tall is called P pulmonale, which is seen in right atrial enlargement. Biphasic P wave is called P mitral, which is seen in left atrial enlargement. Short PR interval is seen in WPW syndrome, and a prolonged PR interval is seen in AV blocks. Okay. Now after the PR interval, we will go to the QRS complexes. Now when it comes to QRS complexes represent ventricular depolarization. Okay. Now the QRS complexes, what can go wrong? Their amplitude can increase or their duration can increase. So when amplitude increases, it should prompt towards either left ventricular hypertrophy or right ventricular hypertrophy. Now how do we diagnose left ventricular hypertrophy? We have a criteria called as Sokolov-Lyon criteria or voltage criteria. So in this criteria, we primarily look at the S wave in V1 and R wave in V5 or V6. Okay, so we have to calculate the amplitude of the S in V1 plus R in V5 or V6. And if this sum is more than 35 small squares, we can declare that patient has got left ventricular hypertrophy, right? So in this ECG example, you can see we are looking at S in V1. The S amplitude in V1 here is 15 small squares, and then we will look at R in V5 or V6. So R here in V6 is having 19 small squares. So 15 plus 19, that will become how much? Around 34. It is not more than 35. So it is unlikely to be a case of left ventricular hypertrophy. But if it was 35 plus, it will be considered as left ventricular hypertrophy. This is like a classical ECG of left ventricular hypertrophy. So here 1, 2, 3, 4, 5, 6, 7. So almost 32, 33 is the amplitude of S in V1. Plus when you look at R in V5 or V6, this also 1, 2, 3, 4. So almost 20. So it is certainly more than 50. More than 50 is definitely more than 35. So according to the Sokolov-Lyon criteria, this ECG has left ventricular hypertrophy. So you have to remember this formula. S in V1 plus R in V5 or V6, wherever it is clearly seen. If this sum is more than 35 small squares, it is left ventricular hypertrophy. Now how to recognize right ventricular hypertrophy, right? So for right ventricular hypertrophy, first thing you should have tall R wave in V1 and tall S wave in V6. Now remember, in a normal ECG, in V1, generally S is the prominent wave, R will be very small, and as you move from V1 to V6, R becomes very large, S becomes very small. Okay. But in case of right ventricular hypertrophy, R becomes prominent in V1 and R becomes prominent in V1 and S becomes prominent in V6. So we will be looking at this thing called as R by S ratio. R by S ratio in V1, if it is more than 1, and in V6, if it is less than 1, it indicates right ventricular hypertrophy. In normal, it will be ulta. Ulta means it will be less than 1 in V1 and it will be more than 1 in V6. Okay, so in this ECG, look at this. I am looking at V1. In the V1, when you look at the R wave, right? R wave amplitude is 1 large square, 2 large square and 2 small square. So it is like 12, right? and this is our S wave. The S wave amplitude is 2. So 12 by 2. 12 by 2 is equal to almost 6. So V1 R by S ratio in V1 is 6. Is it more than 1? Yes, it is more than 1. And look at that in V6. When you look at that in V6, this is 1 large square. R is 1 large square equal to 5, and the S is 1 large square plus 2. So it is equal to 7. So when you look at R by S ratio in V6, it is 5 by 7. It is certainly less than 1, right? Isn't that less than 1? So that satisfies the criteria for the right ventricular hypertrophy. So two criteria for left ventricular hypertrophy: 𝐒𝐿𝐈 criteria, S in V1 plus R in V5 or V6 more than 35 small squares. And for right ventricular hypertrophy, R by S ratio in V1 more than 1 and V6 less than 1 satisfies the case to be called as right ventricular hypertrophy. Now what next about the QRS? We studied about P waves, PR interval. QRS amplitude, we studied how to use amplitude for the diagnosis of left and right ventricular hypertrophy. Now the QRS duration. The normal QRS duration is less than 120 milliseconds. Means less than 3 small square. 1 small square is 40 milliseconds. So in what condition it can be prolonged? It can be prolonged in the conditions that I have listed here: right bundle branch block, left bundle branch block, WPW syndrome, and VT and VF. Okay. Now is it difficult for us to recognize WPW syndrome? No, because in WPW syndrome there will be, in addition to prolonged QRS, there will be short PR interval and there will be a delta wave. So if you see that, you know it is a case of WPW syndrome, right? Then is it going to be difficult for us to recognize VT, VF? No, in VT and VF there will be tachycardia. So if a patient's ECG does not show tachycardia, don't think of VT, VF. So we have to mainly learn how to differentiate between RBBB and LBBB if your QRS duration is prolonged. Okay, and I have told you this is the simplest way to remember it. If you have a wide QRS complexes and the case is not WPW syndrome, the case is not VT or VF, then all you need to do is look at the lead V1. In the lead V1, if you have a predominant wave as R wave is predominant in lead V1, then it is RBBB. And if in lead V1, S wave is predominant, then it is LBBB. Very simple approach, right? Now look at this ECG. When you look at this ECG, first thing I notice is that the QRS duration is wide, right? It starts from here and ends here. So it's like almost 4 small squares. So there is a wide QRS duration. Okay. The second thing, when you have wide QRS duration, it can be WPW, VTVF. I'm sure all of you know that this is not VTVF. The heart rate looks to be normal. And then we are also sure that this is not WPW syndrome, because in WPW syndrome there will be short PR and delta. I don't find a delta wave here. So mainly I have two differential: RBBB, LBBB. Now how to differentiate? I gave you a simplest clue, right? Look for which is a predominant wave in V1. If R was the predominant wave, then it is RBBB. Easy to remember, R for RBBB. In V1, R is the dominant wave, then it is RBBB. In this case, R is only this much. What do I see? I see predominant S wave. So in V1, if S wave is predominant, it is LBBB, right? Simple as that. So this ECG is LBBB. Okay. One last point I want you to remember about bundle branch blocks. RBBB can be physiological in various conditions, but LBBB is considered as pathological always. Okay. So now we have studied about the P waves, then PR interval, QRS complexes. The next thing we will study about is the PR segment. Remember, segments do not include a wave, right? So what can go wrong with segments? Segments do not prolong. Segments go up or go down. So PR segment can be depressed. Where is it depressed? It gets depressed in acute pericarditis. And in acute pericarditis, we do see some additional changes. What are the additional changes we see in acute pericarditis? Sakshi, I will address that, squares and blocks. QT prolongation can be seen in, okay, QT prolongation is typically seen in hypo. Okay. Yashwardhan, after the session, I will give 10 minutes for the meningitis. Okay. So see, in the ECG you have large squares and small squares. Small squares, right, in a horizontal term. See, when you read a ECG in horizontal, it is always about duration. When you read ECG vertically, it is about amplitude or voltage, right? So horizontally it is duration, and if you see a large square which includes 5 small squares, it is called as a large square. Large square represents 200 milliseconds. Small square represents generally 40 milliseconds. Okay. In acute pericarditis, apart from depressed PR segment going below the baseline, we do see some additional changes. What are the additional changes? We see an ST segment elevation which is showing a concavity, and you will have a down sloping TP segment. This down sloping TP segment is called as spodic sign, which is a repeatedly asked MCQ. Where do you see spodic sign? We see that in patients with acute pericarditis, right? So here is one ECG which shows all the acute pericarditis findings. So now look at this ECG, right? This is the P wave, this is your PR segment, this is your ST segment, and this is your TP segment. So when you look at that, right, from the P wave, if I draw a line, we can notice that the PR segment is below, ST segment is elevated, and TP segment starts high and then goes down. The down sloping TP segment is what we call as spodic sign, which is a repeatedly asked MCQ, right? Okay. Now, apart from PR segment, the next thing we need to look at is the ST segment, right? In the ECG, ST segment is probably the most important segment, because the most important diagnosis that none of us want to miss is a case of MI, right? Especially STEMI. So ST segment is a segment between your QRS complexes and T wave. Segment do not include a wave, right? So if I have PR segment, QRS duration, then ST segment, and then T wave. So this segment is what we call as ST segment. From the end of QRS complexes to the beginning of T wave, this is a ST segment. This segment can go below the baseline or go above the baseline. Going below the baseline is depression, going above the baseline is elevation. Now, important causes for ST elevation is one, ST elevation MI. Acute pericarditis, I've already told you the acute pericarditis changes, and the third one is early repolarization. Okay, our focus should be on recognizing the STEMI, right? In a case of STEMI, we will have ST elevation which has certain characteristics. What are the characteristics? There should be elevation of J point. Now, where is this J point? J point is a point at which S wave ends on the baseline. This point will be called as J point. In some leads, we may not be able to see the S wave at all. So in that case, wherever the R wave ends, that will be taken as J point. So this J point should be elevated. If you have J point on the baseline and after that the ST segment gets elevated, in that case we don't call it as the typical STEMI type of ST elevation. The J point should be elevated. There should be elevation in at least 2 anatomically related leads which are representing one particular wall of the heart, and the elevation is generally going to be convex. In case of acute pericarditis, it will be concave. Concave ST elevation in pericarditis, convex ST elevation in case of STEMI, right? And the most important finding that, okay, if you have this, it is a case of STEMI, is reciprocal changes. Now, what are reciprocal changes? In the chest, right, different leads represent different wall of the heart, and remember the leads 2, 3 AVF which are representing inferior wall, and leads 1 and AVL which are representing your lateral wall. They are reciprocal to each other. They are positioned in such a way that they are looking at each other in a opposite direction. So if one lead is going to show ST elevation, the other lead will be showing ST depression. If we see that, like one lead showing ST elevation and a counterpart lead showing ST elevation, opposite changes, we call them as reciprocal changes. And the presence of reciprocal changes is the surest sign of STEMI. The most definite sign of STEMI on ECG is presence of reciprocal changes. Okay. Now you have to recognize a case of MI on the ECG. You have to recognize which wall is affected and which culprit blood vessel is going to be affected. Okay. So now remember, in the ECG, lead 2, 3 AVF represent inferior wall, and the most important blood supply to inferior wall comes from the right coronary artery. 80% of the blood to inferior wall comes from the right coronary artery. Yeah, whenever there is a question about the inferior wall, most common supply is the right coronary artery. So your answer should be right coronary artery, because questions are framed in a such a way that what is the most likely, question never says is the only cause. Question will ask what is the most likely cause. Most likely cause for inferior MI will be occlusion of RCA, because RCA is responsible for the 80% of the blood supply, right? Only in 20% it will be left circumflex. Okay. Next, lead V1 and V2 represent our interventricular septum. Primarily it is supplied by septal branches of LAD. Yes, there is also a slight supply from the RCA. Then V3 and V4 represent anterior wall, and anterior wall is supplied by the left anterior descending artery. And last, one AVL represents higher portion of the lateral wall, and V5, V6 represent the lower portion of the lateral wall. This lateral wall is supplied by the branch of the left main coronary artery called as left circumflex artery. So lateral wall MI, you should suspect circumflex artery occlusion. Anterior wall MI, you should suspect the LAD occlusion. Inferior wall MI, first thing you should suspect the right coronary occlusion, and rarely the circumflex branch occlusion, right? Okay, so please go through some of the ECGs so that you can pick up which wall and which vessel is affected. Like for in this case, I can notice ST elevation in V1, V2, V3 and V4, right? V1 and V2 is representing septum, and V3, V4 is representing anterior wall. So this patient has anteroseptal MI. So which blood vessel is most likely a culprit in this case? Anteroseptal MI, right? Anterior is supplied by LAD, septum is also supplied by branches of LAD. So I can say that it is primarily LAD block which is responsible for the septum and anterior wall getting affected, right? So this is one table which I want you to memorize. The leads, which wall, and what is their blood supply. This will ensure you that you will most likely Sakshi, what is the confusion? If you text me what is the confusion, I will try to address that. Okay. So in ST segment, okay, I will give you a small table. See, in the heart, when you look at the heart, right, heart has a inferior wall which is resting on your diaphragm. Then it has a lateral wall on the lateral side, right, and it has a anterior wall. This is anterior wall. Now the blood supply to heart comes from two blood vessels. One is the right coronary artery, which primarily supplies the inferior wall. The second one is left coronary artery. This left coronary artery divides into two branches. One is called as LAD. This branch is called as LAD, and the second one is called as left circumflex. So this left circumflex supplies the lateral wall, and LAD supplies the anterior wall, and some branches of LAD will also supply interventricular septum. Behind the anterior wall, between two ventricles, is the interventricular septum, that is also supplied by LAD. So if you have a MI involving the inferior wall, most likely the right coronary artery will be occluded. If you have a MI involving the anterior wall or the interventricular septum, most likely left anterior descending artery will be occluded. When you have an MI of the lateral wall, most likely the left circumflex artery will be occluded. Now how to identify whether the MI is affecting the inferior wall, lateral wall or the anterior wall? By looking at the leads. So inferior wall on the ECG is represented by lead 2, 3 AVF. So if you have ST elevation in 2, 3 AVF, it means you have inferior wall MI. If you have ST elevation in lead 1 AVL, V5 or V6, that means you have a lateral wall MI, most likely because of the circumflex occlusion. Then if anterior wall is represented by lead V3 and V4. So if you have a ST elevation in V3, V4, it means you have the anterior wall MI. Okay, I will explain the reciprocal changes. And your interventricular septum is represented by V1 and V2. So if you have ST elevation in V1 and V2, you have interventricular septal MI, right? Now lead 2, 3 AVF and 1 and AVL. They are looking at each other in the opposite direction. So if you see ST elevation in lead 2, 3 AVF, there should be ST depression in 1 AVL because they are looking at the same location in opposite directions. So if one is showing ST elevation, the other should show ST depression. Then only it is a case of STEMI. And this is what we call as reciprocal changes. So if I have a lateral wall MI, there will be ST elevation in 1 and AVL. In that case, 2, 3 AVF should show ST depression. If I have inferior wall MI, there will be ST elevation in 2, 3 AVF and then 1 and AVL should show ST depression. This is what we call as reciprocal changes. Let me see if I have an ECG with reciprocal changes. Okay, here is an ECG where reciprocal changes are evident. You might notice that there is ST elevation in the lead 1 and lead AVL. So when there is ST elevation in 1 and AVL, what should happen to 2, 3 AVF? There should be ST depression, which you can see here, 2, 3 and AVF, right? The ST segment is below the regular baseline. This is what we call as reciprocal changes. So if I see reciprocal changes, that means it's a sure sign of MI. Okay. Now what other ECG points we need to remember? Just few more, right? Tall T waves, where do we see? We see them in hyperkalemia and MI. In MI and hyperkalemia. In MI, tall T waves are the earliest changes, and in that case we call these T waves as hyperacute T waves. That is also an MCQ where we see hyperacute T waves. Okay. Then apart from that, we can have inverted T waves. Inverted T waves, generally the most common cause for inverted T wave is old infarct. So whenever an MI happens, first thing is T wave becomes tall, then ST segment becomes elevated, then slowly ST segment becomes depressed, and eventually T wave becomes inverted. Apart from that, we can also see in hypokalemia, WPW syndrome and left ventricular hypertrophy. Not important, as long as you remember tall T waves equal to hyperkalemia and MI, it's kind of enough. Okay, so that completes our ECG, but I will put a small page here for us to remember all the important findings. So with respect to P wave, right, tall P wave is called as P pulmonale. P pulmonale, which is seen in right ventricular hypertrophy, right? Then bifid P wave or biphasic P wave. Biphasic P wave is called as P mitral. Sakshi Modi, both are depressed, it is not a case of STEMI. That's what I told. If I see reciprocal changes, that's the surest sign of STEMI. If 1 and AVL is showing ST elevation and there is no depression in 2, 3 AVF or vice versa, it is not a case of STEMI. Okay. So when I have bifid P waves, we call it as P mitral. It indicates right atrial hypertrophy. It indicates left atrial hypertrophy. Okay. Then PR interval. PR interval, if it is short means less than 3 small squares. That means it is a case of, first thing that should come to your mind is WPW syndrome, right? Now what additional findings we see in case of WPW syndrome? We will also have a delta wave and we will also have wide QRS complexes. Wide QRS complexes. Okay. Then where do we have a prolonged PR interval? Prolonged PR interval. Prolonged PR interval means more than 5 small squares. We typically see that in AV blocks, right? AV blocks, repeatedly asked MCQ. So first degree AV block, only prolonged PR interval. There will be no missed QRSs. In the second degree Mobitz type 1, Mobitz 1, there is serial prolongation of PR till a missed QRS. Till a missed QRS. In the second degree Mobitz type 2, you have constant PR interval, yet you have a missed QRSS. And in the third degree heart block, you have AV dissociation, no relationship between P waves and QRS. P wave appear randomly, QRS complexes appear randomly. Okay, so this is about your PR interval. Next is PR segment. Remember, interval contains a wave, segment do not contain a wave. PR segment gets depressed. PR segment depression is seen in only one condition, and that is acute pericarditis. Okay, in acute pericarditis, I have told you some important ECG changes. The other important ECG changes you need to remember here is that this will have, in addition to the PR segment depression, you will have ST segment elevation, and how that will be concave here and it will be convex in MI. Plus you will have down sloping TP segment, down sloping TP segment, down sloping TP segment, which is called as Spordig sign, Spordig sign. Okay, then in terms of next important parameter, that is your QRS complexes, right? In QRS complexes, we can recognize left ventricular hypertrophy with Sokolov-Lyon criteria. In this criteria, all we need to look as S wave amplitude in V1, S in V1 plus R in V5 or V6. If it is more than 35 small squares, then we will call it as left ventricular hypertrophy. How to recognize right ventricular hypertrophy? Right ventricular hypertrophy, mainly we will look at R by S ratio, right? In V1, if it is more than 1, and in V6, if it is less than 1, it indicates that you have right ventricular hypertrophy. Okay. Now, in next thing we studied was the ST segment. ST segment, mainly we should remember STEMI, and I have already discussed about which leads represent which valves and what is the blood supply. So please remember that table. So this is one important page which might give you one mark on the ECG. One of this can be asked, right? So please be aware about that. Okay. Now from here we will quickly move to the arrhythmias. One MCQ is almost every year expected on arrhythmias. Now arrhythmias, I will only give you the approach, how to recognize which arrhythmia it is on the ECG and how to manage, right? So any case of arrhythmia, the first thing you should see is what is the QRS duration. What is the normal QRS duration? Normal QRS duration is less than 120 millisecond, right? Normal QRS is less than 120 milliseconds. That means less than 3 small squares, because 1 small square is equal to 40 milliseconds. So if it is more than 120 milliseconds, such tachyarrhythmias will be called as wide complex tachycardias, and if it is less than 120 milliseconds, such tachyarrhythmias will be called as narrow complex tachycardias. Okay, so first thing, the moment you see an arrhythmia ECG, first thing is see the QRS duration. If the QRS is more than 3 small squares, it is wide complex tachycardia. If it is less than 3, it is narrow complex tachycardia. After that, we will see how to approach. What are the examples for wide complex tachycardia? VT, VF. Only 2 things you need to remember. Don't bother about this SVT with aberrancy. That is not for the FMGE or NEET PG students. It is only for INI CT and NEET SS. Any tachycardia, heart rate more than 100 and QRS complex is more than 3 small square, it is going to be practically VT or VF. Okay. And if the QRS complexes are narrow, less than 3 small square, and there is tachycardia, in that case, you have a possibility of sinus tachycardia, atrial tachycardia, multifocal atrial tachycardia, atrial fibrillation, and SVT. So we will learn how to approach it. Okay, Prajapati, there are certain criteria which help us to differentiate between SVT and SVT with apparent conduction. At this point of time, not required for students who are going for FMG. But if you want to know, you can DM me, we will discuss about it. I do not want to overburden with the information for the exam going students. Okay, so first we will learn how to identify different types of narrow complex tachycardia. Now to identify different types of narrow complex tachycardias, right, first thing we have to look at is the presence or absence of P waves. Now please remember one thing here. In the ECG, many things will look like P waves. Until and unless you can confidently identify it as a P wave, it is not a P wave. Means it should look like a proper P wave. Then only you can say P wave is present. If there is something looking like some haphazard change on the baseline, it is not always a P wave. Okay. So if P wave is present, then it can be sinus tachycardia or atrial tachycardia or multifocal atrial tachycardia. Sinus tachycardia, how to identify? In sinus tachycardia, right, every P will be followed by a QRS. So all you need to do is in the ECG, you may get one strip at the bottom of the ECG called as rhythm strip. Let me see if I have a ECG for you to show the rhythm strip. Okay, we call that as rhythm strip, which is there in the bottom of any ECG. So look at that rhythm strip. Generally lead 2 is used as the rhythm strip, and in the rhythm strip, right, count the number of P waves and count the number of QRS complexes. If both are equal, then it is sinus tachycardia. If one P is followed by QRS, next P, next QRS, next P, next QRS, then it is sinus tachycardia. But if you find that there are more P waves in comparison to the QRS complexes, then it will be atrial tachycardia. P waves equal to QRS, sinus tachycardia. More number of P waves, less number of QRSs, atrial tachycardia. And there is a variant of this atrial tachycardia called as multifocal atrial tachycardia. See, it is there in the name. What is the name? Multifocal means different areas of the atria are acting as a focus for initiation of the impulses. In that case, P waves will also look differently. So if you have P waves which look different from each other, not all P waves are same looking, then you can call it as multifocal atrial tachycardia. And I want you to remember one MCQ point about it. The multifocal atrial tachycardia is the pathognomonic arrhythmia of COPD. It is only seen in patients with COPD. Multifocal atrial tachycardia is only seen in patients with COPD. Remember this. This is a potential MCQ point. Okay. So if you have a P wave present and tachycardia, these are the possibilities. But when you have absent P waves, this is where most of the MCQs are asked. Narrow complex tachycardia with absent P waves, we have two differential diagnoses. It can be either atrial fibrillation or supraventricular tachycardia or SVT. Now how to differentiate between these two? In atrial tachycardia, all we have to see is the RR interval. RR interval will be, in atrial fibrillation, the RR interval will be varying from one beat to the next. RR interval will be becoming shorter, wider, then it is atrial fibrillation. If the RR interval is constant, then it is SVT, right? So let me just pose some images and see if we can identify whether that particular ECG is atrial fibrillation or SVT. Okay, so just give me 1 second. I will just bring in some ECGs for us to recognize what are we dealing with. Okay, so look at this ECG and tell me, right, this patient, as we quickly see that this patient has tachycardia, so I should be suspecting tachyarrhythmias, right? So what is this? Does this patient have narrow QRS complexes or wide? See, remember this. What is the approach? Any case of arrhythmia, first thing is look at the QRS duration, whether it is wide complex or narrow complex. So when you look at this ECG, what is the duration of QRS? It's only barely one small square, right? So this is a narrow complex. When we have narrow complex tachycardia, what should we see? We should see whether there is a P wave present or not, right? So if there is P wave absent, then it could be atrial fibrillation or SVT. In this case, there is no clearly identifiable P wave. Okay, you may say, sir, what about this? Isn't this P wave? The answer is no. The first thing is that T waves are generally not absent. So whenever you are confused कि this is P wave है या T wave है, तो जो भी आपको लगता है एक पॉजिटिव वेव है उसको T के नाम से लेबल करो और फिर ढूंढो कि P wave मिलता है या नहीं, क्योंकि T wave absent is extremely rare, P wave absent is common. तो ये T है तो P कहाँ है? P नहीं है, right? So when there is no P wave, then it is narrow complex tachycardia with absent P wave. So then in that case, we have only two differential diagnoses, atrial fibrillation and supraventricular tachycardia. Now how to differentiate in that case? In atrial fibrillation, RR interval will be varying, it will not be constant. In supraventricular tachycardia, it will be constant. So in this ECG, RR interval is varying or constant? Is it same in all the beats or it is varying? Just one look tells us that it is same in all the beats. So in that case, it is a case of supraventricular tachycardia, right? What do we see here? Narrow QRS complexes, absent P waves and constant RR interval. But now look at the next ECG. When you look at this ECG, here also the QRS complexes are narrow, not very wide, and we cannot clearly identify a P wave. I have already told you some baseline artifacts, don't call them as P wave. You should have something which clearly looks like a P wave. I don't have anything that clearly looks like a P wave, so this is certainly not a positive P wave case. So we have narrow complex tachycardia with absent P waves. And what is happening to the RR interval? Look here and look here. The RR interval is not constant, it is varying from beat to beat. RR interval is varying, so that means this is a case of atrial fibrillation, right? So now we have learned how to recognize atrial fibrillation and supraventricular tachycardia. Next we will learn how to recognize VT and VF. VT and VF, right? VT and VF will be characterized by wide QRS complex. The moment you see that QRSs are looking wide, it is likely to be a VT or VF if there is tachycardia. If there is no tachycardia, it could be WPW syndrome, RBBB, LBBB. How to identify that? We have already learned, right? Now in VT, what happens is, VT is of two types. We call them as monomorphic and polymorphic. In monomorphic, if you take any lead, in a particular lead, all the QRS complexes are of same amplitude and they look same. That's why it's called as mono. Morphology is same, monomorphic, like this. All looking same in a given lead. In polymorphic, within one lead itself, the amplitude and the look of the QRS complexes will be changing. In that case, we call it as polymorphic VT. And there is one type of polymorphic VT. There is a type of polymorphic VT which is called as a type of polymorphic VT which is called as Torsades de Pointis. Torsades de Pointis. Okay, I will tell you how to identify Torsades de Pointis. It is nothing but a polymorphic VT. I'll tell you how to identify. But before that, how to identify ventricular fibrillation. First thing is, the word fibrillation means the ventricle is merely shaking and not contracting, right? When it is shaking, obviously its amplitude will be small. So you will have low amplitude complexes, wide complexes which are of low in amplitude. And second, there will be significant variation in the amplitude. Then we call it as ventricular fibrillation. Okay, so let me give you 3 ECGs and you only identify which one of them, right? What is this ECG? All of us agree that the QRS complexes are very wide, right? Wide QRS complexes. And you take any lead, all the QRS complexes in one particular lead look same, right? Look at V4, all the QRS complexes look same amplitude. Look at V1, all the QRS complexes look same and same amplitude. So then what is it? Wide QRS complexes with same amplitude in any given lead. That is nothing but a typical case of monomorphic VT, right? Monomorphic VT. Now in the second ECG, what do you notice? In the second ECG, the QRS complexes are wide, right? They are more than 3 small square, almost 5 small squares. But when you look at the amplitude is not small, it looks normal, but amplitude is varying within a lead. Take any lead, right? Amplitude is increasing and decreasing within a given lead. Like this is AVF. In the AVF only, amplitude is increasing, decreasing. This is V3. In the V3 itself, amplitude is increasing and decreasing. So they don't look same. So that means it is going to be a case of polymorphic VT, right? And then look at the third ECG. First thing that comes to your mind is that the QRS complexes are wide, right? They are wide and there is tachycardia. And then what we notice, the amplitude of these complexes is quite small, right, in comparison to the other two ECGs which we saw. The amplitude is very small and there is a significant variation in the amplitude. So that means this is mostly a case of ventricular fibrillation or VFib. Clear? So you should be able to identify SVT, atrial fibrillation, VT, monomorphic as well as polymorphic, and VFib. Okay. Now one last point about the ECGs. I told you to remember something called as Torsades de Pointes, right? Torsades de Pointes. I am emphasizing this because I saw a question in the recently concluded INI CET, so this might spill over to the FMGE also. Now what is Torsades de Pointes? It is a type of polymorphic VT. Yeah, I will cover. It's a type of polymorphic VT where you will have twisting of QRS axis along baseline like a waveform. Okay. Now remember, when I say like a waveform, what does that mean? So think of this as a baseline, right? This is a ECG baseline. Now what will happen to QRS complexes? QRS complexes, like initially they may be prominently upright, okay, and then they will become prominently downright, then again prominently upright. So it looks like a waveform. Polymorphic VT, amplitude is not same, it is varying within a lead and it is giving the appearance of a waveform. Then we call it as Torsades de Pointes, right? And the most common cause for Torsades de Pointes is hypomagnesemia. Now this is not monomorphic VT because within one lead only all this is happening, not in different leads. Within one lead, amplitude is increasing, decreasing, and it looks like it is twisting around the baseline like a wave. Then we call it as Torsades de Pointes. Okay. Now the last point we need to learn about the ECG is how to identify the how to manage these cases, right? Okay. First we will take up the management of the SVT. How do we manage a case of SVT? Any arrhythmia, the management's first objective will be to see what is happening with the BP. If patient is in hypotension, there is only one way to treat it, to give shock. If the patient is not in hypotension, then we can think of giving the drugs and converting the rhythm to normalcy. Any arrhythmia, VT, SVT, atrial tachycardia or ventricular fibrillation, anything. If patient is in hypotension, shock, right? So in case of SVT, if BP is less than 90/60, we give shock. And the type of shock that we give is called as cardioversion. Okay. So we have to understand what is the difference between cardioversion and defibrillation. So I have put a small table differentiating between cardioversion and defibrillation. In cardioversion, what we do is we try to give the shock to the R wave. Why we give it to R wave? Because we don't want to give the shock to T wave. QT prolongation is, yes, one of the finding of the torsade. Yes, it is related to potassium channel blocker. Okay. Now in cardioversion, we give the shock to the R wave and we don't want to give it to T wave because T wave represents what? Ventricular repolarization. When repolarization is happening, if I give shock, I block the repolarization and keep the ventricle in a state of depolarization. That can increase the risk of developing ventricular arrhythmias. Right? So if I have supraventricular arrhythmia, I may convert it into ventricular. We don't want to do that. So that's why in cardioversion, we give it to R wave. And when we do cardioversion, we generally start with lower electrical energy and we keep increasing. Typically, cardioversion is used for supraventricular arrhythmias like SVT, atrial fibrillation, atrial tachycardia and all. And when arrhythmia originates in the ventricle, we don't have a fear of converting the arrhythmia to ventricle because it's already a ventricular arrhythmia. In that case, we don't need to synchronize it with R wave. We can directly give without synchronizing it with the R wave. That is what we call as defibrillation. And defibrillation, we always start with high energy, right? So defibrillation is typically followed for our ventricular arrhythmias, VT, VF. We do defibrillation. SVT, atrial fibrillation, we do cardioversion. So in case of the SVT, obviously, if BP is low, we do cardioversion. Okay. But if BP is good, more than 90-60, first we try to do basic vagal maneuvers. Now what do we do in vagal maneuvers? We try to do carotid massage or Valsalva maneuver. Vagus nerve, if it is stimulated, it will slow down the heart rate and it can help you to convert the SVT to normal sinus rhythm. Not very effective. If it fails, we have to think of drugs. The drug of choice here is going to be adenosine. Repeatedly asked MCQ. Another MCQ is the side effect of adenosine. Adenosine can cause bronchoconstriction and that is why it is contraindicated in patients with asthma. Okay. Now, adenosine being very short acting or a very short half-life of few seconds, it should be preferably given with a central line, and after giving the drug, we should push the line with saline so that it quickly reaches the heart. The first dose we give 6 mg. If it fails, you can do second and third dose with the 12 mg. If that also fails, then you don't have a choice but to go for cardioversion. This is the approach to management of a case of your supraventricular tachycardia, right? All these are important MCQ points. Okay. Now when it comes to the wide complex tachycardias like VT and VF, how do we approach or how do we manage? Again, same question, what is happening to the BP? If it is VT or VF, especially VT, right? VF, remember, VF is generally without pulse because in ventricular fibrillation, ventricle is not contracting, it is shaking. Pulse is generated by ventricular contraction. When ventricular ejection happens, pulse comes. If it is not contracting, no pulse, right? So if you have a patient with wide complex tachycardia, mostly VT, poly or mono, if the BP is fine, you can try to treat it with drugs. The drug of choice here will be amiodarone. Alternatively, we can use also lignocaine. Why amiodarone is a drug of choice? Because it is a broad spectrum antiarrhythmic. Even if by mistake you have misdiagnosed a SVT as VT, amiodarone will take care. But if it is SVT and you give lignocaine, it can be catastrophic, right? Now in a wide complex tachycardia, if patient is pulseless, if the BP is less than 90-60, look at the pulse. If it is pulseless can be either because of VF or it could be a VT without pulse. In those cases, there is no pulse, means brain is not getting blood. So first thing is start CPR and follow all that you have learned from the anesthesia about the ACLS protocol. Follow that for the CPR. All these are important MCQ points indeed. But if you have low BP but pulse is felt, it is most likely going to be VT only. VF generally we don't feel pulse. Ideally, you should go ahead with the defibrillation. Remember, cardioversion for supraventricular and defibrillation for the ventricular arrhythmias. That is our approach to the management of the arrhythmias. So far we have discussed quickly about the ECG and arrhythmias. The next thing we will do is we will take a quick discussion on the heart failure, because you can anticipate plenty of questions from the heart failure. Okay. Now what is heart failure? Heart has two functions, right? Heart receives the blood and pumps the blood. If it is unable to receive or unable to pump, that is what we call as heart failure, right? Failure to receive or failure to fill the ventricles or failure to eject from the ventricle is called as heart failure. In both the cases, the symptoms are going to be similar, whether it is failure to receive. Failure to receive is a dysfunction of the diastole. During diastole, ventricle should dilate to receive, and during systole, they should contract to eject. Systole or diastole, anything problematic, then patients will have same set of clinical features. Why? Because if less amount of blood fills the ventricle because of diastolic dysfunction, less amount of blood will be ejected out. If you have a systolic dysfunction, good amount of blood fills the ventricle, but because contraction is weak, again less amount of blood will be ejected. So ultimately patient will have fatigue because the cardiac output will be decreased. Second, when ventricles cannot eject, right, the accumulation of blood in the ventricle means that ventricle pressure is high. That pressure will reflect onto your left atrium. From there it will reflect onto your pulmonary veins. Eventually it will cause stasis in the lungs, what we call as pulmonary congestion, and that can lead to dyspnea. And another symptom of heart failure, as we all know, will be pedal edema, right? These are the typical features of heart failure. Heart failure we can categorize as right heart failure and left. Now, how to identify whether patient has got a failure of right heart or failure of left? It's very simple. So in right heart failure, ultimately whatever pressure that builds up in the ventricle will be reflected to right atrium, and we will have symptoms related to increased pressure in the right atrium. What are the symptoms? We can see raised JVP, right? And then the blood from liver also reaches the inferior vena cava. So if the right atrial pressure is high, the blood from liver cannot reach inferior vena cava. Blood starts stagnating in liver. We call it as congestive hepatomegaly. In pathology, you call it as nutmeg liver, right? Or chronic venous congestion of liver. And once there is congestion of liver, patients will develop jaundice, cirrhosis, and portal hypertension, right? So one of the causes for portal hypertension is also right heart failure. Then right heart failure will also lead to ascites and pedal edema. Now when you have a left heart failure, there is rise in left atrial pressure, and that rise in left atrial pressure will lead to back pressure and congestion of the lungs. Congestion of the lungs will lead to dyspnea. And in addition to dyspnea on exertion, this patient becomes short of breath when they lie down. We call it as orthopnea. Shortness of breath on lying down. In orthopnea, shortness of breath appears immediately on lying down, and it gets relieved immediately on getting up. Immediately I lie down, I become short of breath. I get up, immediately I will be relieved. The purpose or the main reason behind this is two. One, when I lie down, the diaphragm goes up, restricting the lung expansion. If I already have the congestion of the lungs, then I will not be able to oxygenate well, and I will feel short of breath. When I sit upwards, the diaphragm goes down, there is more space available for the lungs to expand, and I'll start feeling eased or relieved of dyspnea. But remember, orthopnea is not specific for heart failure, because anything that pushes the diaphragm up can also cause the symptoms, like the paralysis of the phrenic nerve, injury to the phrenic nerve, or if there is too much of ascites, that can also push the diaphragm up, and I can experience orthopnea. But then we have another condition called as PND, paroxysmal nocturnal dyspnea, or PND. The PND is a specific finding of left heart failure. It's a specific finding. Why? Because PND, there is shortness of breath around like 1.5 to 2 hours after patient going to sleep. He will feel short of breath, get up, and then around 30 to 45 minutes after he gets up and takes the upright posture, he will feel relief. The reason behind that is two. One, when I lie down and go into sleep, slowly all the fluid that was there in my legs as edema will come back to veins. From the veins, it will come back to the right heart. From the right heart, it will go to lungs and cause congestion there, because it cannot go to the left heart because pressure on the left side is already high. The second thing, 90 to 120 minutes after I go to sleep, I get into a phase of sleep called as REM phase, where I start dreaming. When I am dreaming, my sympathetic nervous system gets activated, and this activation, right, will demand increased blood supply to the heart. A failed heart cannot give itself sufficient blood supply, and it will fail more transiently, so its action will come down further. That's why 90 to 120 minutes after I go to sleep, I will start developing shortness of breath. Now once I get up, the fluid that has come to the lungs will take some time for it to go down to the legs as edema, and that is why I don't see immediate improvement. I will take some time to get relief from the shortness of breath. So in case of orthopnea, immediate shortness of breath on lying down, immediate improvement on getting up. In case of the PND, takes some time for the shortness of breath to appear on sleeping, and takes some time for the shortness of breath to disappear after taking a upright posture. That is the main difference. And remember, PND is the most specific symptom of left heart failure. Now moving on, we have to study about the classification of heart failure. We classify the heart failure based on the ejection fraction. You might have studied about ejection fraction in physiology. You should know the formula. Ejection fraction is nothing but stroke volume. What is stroke volume? The quantity of blood pumped by the ventricle in one systolic contraction. That is stroke volume. Right? Ejection fraction is equal to stroke volume divided by end diastolic volume. What is end diastolic volume? At the end of diastole, how much blood is there in the ventricle? Basically, diastole, the ventricle gets filled from the atria. So whatever amount of blood is there in the ventricle, by the time the diastole is over, is end diastolic volume. Out of this end diastolic volume, how much percentage blood is ejected by the ventricle is equal to ejection fraction, right? It is expressed as percentage. The normal ejection fraction is 60 to 70%, right? Most of us will have around 60-65% as our ejection fraction. Now in heart failure, as I've already told you, heart has two functions: receive, pump, right? So if pumping is good, ejection fraction will be normal, but if the receiving is not good, still it is heart failure. And if receiving is not a problem but pumping is a problem, in that case the ejection fraction will be low. So based on the ejection fraction, we classify the heart failure as heart failure with reduced ejection fraction when EF is less than 40%. And when EF is more than 50%, we call it as heart failure with preserved ejection fraction. And when it is between 40 to 50%, we call it as mid-range. I certainly want you to remember this number. To call it as reduced, EF should be less than 40%. To call it as preserved, it should be more than 50%. Okay, clear? That is the classification. Now, before we move on to the diagnosis and management of heart failure, a quick list of causes for heart failure. This is going to be an MCQ. What is the most common cause for heart failure? Most common cause for heart failure is going to be hypertension, right? And apart from that, ischemic heart disease is the second most common cause for heart failure. And then you have cardiomyopathies, basically diseases of the cardiac muscle. They can also cause heart failure. Okay. Now, how to diagnose heart failure? Earlier, we had a criteria for heart failure called as Framingham heart failure criteria, which we no longer use. It's called as Framingham heart failure criteria, which is no longer used. Framingham heart failure criteria. This is not used anymore, but I want you to remember the name because sometimes they do ask you the name of the diagnostic criteria. Okay. Now, the current criteria that we follow is called as WHO criteria. In the WHO criteria, all we need for the diagnosis of heart failure is guys, am I audible to you or is there any technical issue? Okay, I guess there is a slight shift of the video, so give me 1 second. Just give me 1 second, guys. Okay, so am I visible to you? Okay, fair. So in the WHO criteria, we recognize the heart failure with symptoms. There should be signs and symptoms of heart failure, and we need to prove that these symptoms are because of heart failure. How do we prove? By elevated BNP or N-terminal proBNP levels. Now, what are these BNP and N-terminal proBNP? These are natriuretic peptides secreted by the heart whenever its chambers are stretched. When the chambers will get stretched, when the flow into them increases, right? So if there is a right atrial or left atrial pressure increasing, they are getting stretched and they release these natriuretic peptides. So if there is BNP more than 35 picogram per ml or N-terminal proBNP level more than 125 picogram per ml, along with signs and symptoms of heart failure. What are the signs and symptoms? Raised JVP, tender hepatomegaly, right? Ascites edema, features of right heart failure. Dyspnea, orthopnea, PND, features of left heart failure. Now, with these symptoms, if BNP is more than 35 or NT proBNP is more than 125, it means it is a case of heart failure. This is our current criteria. We no longer follow the Framingham criteria. Okay. So now we know how to classify heart failure into reduce ejection fraction, and preserve. Preserve means EF more than 50%, reduce means less than 40%. Anything in between is called as mid-range EF. Then we know how to diagnose heart failure. Any patient with signs and symptoms of heart failure, if their BNP is more than 35 or N-terminal pro-BNP is more than 125, we diagnose the case as heart failure. Now, before we go to management, we will just quickly discuss about the pathophysiology of heart failure. That will help us to identify the, learn the management. Whenever heart is failing, the cardiac output starts decreasing. That means the blood pressure will start decreasing. That means there will be reduced renal perfusion. And once there is reduced renal perfusion, there will be activation of the RAS axis. RAS has two components. One is angiotensin 2. Angiotensin 2 will cause vasoconstriction. Vasoconstriction can make the BP get back to normalcy. Second component of the RAS is our aldosterone, right? Now what this aldosterone will do? This aldosterone will increase the sodium and water reabsorption at the level of kidneys, and this sodium and water reabsorption will increase the circulating volume. That can also normalize the BP. But unfortunately, these are going to create problems to the heart. How are they going to create problems to the heart? Because whenever there is vasoconstriction, that means your blood vessels are constricted, and now your heart needs to pump against this resistance of the constricted blood vessels. This resistance against which heart needs to pump is called as afterload. So now by activating RAS, I am increasing the afterload. The second thing, the amount of blood that ventricle needs to eject is called as preload. So if circulating blood volume increases, then amount of blood reaching the ventricle will also be increased. Now this extra blood ventricle needs to pump. So that means the preload gets increased. Unfortunately, increased work burden on the ventricle will make it fail more. So this activation of RAS may get your BP back to normalcy, but unfortunately it is more damaging to the heart. So when it comes to treatment, we should certainly block this RAS, because this is maybe helping you get a better BP, but it is worsening your heart failure, making you die early. On the other hand, there is one more system that gets activated when heart is failing. Because when heart is failing, right or left atrial pressure is increasing, and it is releasing the natriuretic peptides like ANP, BNP. Remember, we used BNP for the diagnosis of heart failure. Now these, as the name says, natriuretic peptides, they will stimulate the release of, they will act on the kidneys to increase the excretion of sodium and water. So when they increase the excretion of sodium and water, the circulating blood volume will come down, because you're losing a lot in the urine. So when the blood volume comes down, the amount of blood reaching the ventricles will also come down. So ventricle needs to eject less quantity of blood. So the preload will come down. So when we decrease the preload, we are reducing the burden or workload on the ventricle. This will be beneficial to heart. So when it comes to management of heart failure, we need to block RAS, and we need to increase the efficacy of ANP or BNP. How can we increase the efficacy of ANP or BNP? Generally, ANP, BNP, once they are released, they are degraded or broken down by an enzyme called as neprilysin. So if I inhibit neprilysin, then I can make ANP and BNP levels go high, and that can be helpful for a patient with heart failure. Clear? So when it comes to management of heart failure, we need to block RAS and support neprilysin, inhibit neprilysin, and thus support the ANP, BNP. So any patient of heart failure, the first thing that we should start is an AC inhibitor or ARBs. The reason for that is because angiotensin is vasoconstricting, causing increased afterload, worsening heart failure. So we should block. Plus, we also give patients beta blockers. Why we give beta blockers? Because beta blockers will decrease the, they will cause vasodilatation, and they will decrease the force of contraction of the left ventricle. As a side effect, we can have decrease in cardiac output, but they are certainly decreasing the workload on the heart. Heart doesn't need to contract with force anymore, and it doesn't need to contract against the resistance created by the constricted blood vessel. So burden on the heart is coming down, so it can make heart live longer, right? The only problem with beta blockers is that they decrease cardiac output, so patient can experience syncope, fatigue, and orthostatic hypotension. So for that reason, we should always start at low dose and titrate according to the patient's tolerance. Slowly you build up the dose. Okay. Then the third drug that we give for all patients is going to be spironolactone. Why are we giving spironolactone? Because we have to also block the aldosterone, which is increasing the preload. So we give spironolactone to all the patients. And nowadays, since last 2 years, we have started adding one more class of drugs to all the patients, that is SGLT2 inhibitors, because SGLT2 inhibitors decrease the glucose absorption in the kidney, making you lose a lot of glucose in urine. And remember, glucose will not go alone, it will take water also along with that, and thus we will lose a lot of water, and thus we will do a preload reduction, which is also going to be beneficial for heart failure. Okay, so this is a standard initial first line management: AC inhibitors or ARB plus beta blockers plus spironolactone plus SGLT2 inhibitor. This is how we start. After that, if they are not responding, they still have symptoms of heart failure, then we can think of, see, we have already explored this axis, we have blocked it. Now we can think of supporting the natriuretic peptides by inhibiting the neprilysin. We can add a neprilysin inhibitor. As of now in India, only one neprilysin inhibitor is approved for marketing, that is sacubitril. And remember, sacubitril comes with, it is not available as a single drug, but it comes with a combination of valsartan plus sacubitril. Now remember one point here, when it comes to the time of adding sacubitril, the patient will already be on a AC inhibitor or ARB. This AC inhibitor or ARB which patient is taking should be stopped, because sacubitril comes with valsartan, which is a ARB, and we don't give two AC inhibitors or two ARBs or an AC inhibitor plus ARB together. No need for doing that, right? Now all the drugs that I mentioned so far, AC inhibitors, beta blockers, spironolactone, SGLT2 inhibitors and neprilysin inhibitors, all of them are associated with decrease in the mortality. So when you start these medications, patient's death risk will come down. Okay. Now in pharmacology, you might have studied about the digoxin, right? But as a physician, we don't use digoxin, because digoxin, how it works, it's a inotropic agent. It will stimulate the ventricle to contract with more force. It will improve the cardiac output. By improving the cardiac output, it will reduce patient's symptoms. But what is happening to the ventricular workload? We are stimulating it to do more. It is a failing heart, so it will fail faster. So it will lead to death faster. That is why studies have shown that digoxin is associated with increased mortality. That's why we no longer use it in patients with heart failure, no matter what it is, because we have better drugs available with us. Okay. Last point, what about the loop diuretics? Spironolactone to pata hai, right? It is indicated, it reduces the mortality by tackling the RAS axis. What about loop diuretics like furosemide or torsemide? They neither increase mortality nor decrease mortality. They are neutral on mortality, and if patient symptoms demand for the use of it, we can use it. Clear? If patient symptoms demand for the use of it, we can use it, but they don't give you a mortality benefit. So which class of drugs give you mortality benefits? AC inhibitors, beta blockers, spironolactone, SGLT2 inhibitors and neprilysin inhibitors. Which drug is associated with increased mortality? That is digoxin. Okay, so guys, I think I will wind up for today. Okay, I guess some of you probably have the mock exams on the platform on certain platforms tomorrow. So tomorrow I will give it a miss. Day after tomorrow we will again continue with the quick revision sessions, and if you have any questions that you have faced in the mock exams and you have difficulty, that also I will try to address, and also I'll try to come live to discuss the mock questions. Those who are looking for the PDF, I will share it on the Telegram. I will put the link in the comment section, and if you have any specific doubts, you can certainly DM me on the Telegram and I will discuss there. I know I have not taken some of your doubts because I didn't want to overload the information to those who are just focusing on the exam. What is important, I have tried to address. The doubts which are beyond FMGE's importance, you can DM me and we will discuss it over there on the Telegram. Thank you guys. Have a good night and all the best for the upcoming examinations. Thank you. Yeah, I will, in the Telegram, I will post a short note on the ECG, and I am compiling a table of all the clinical findings of valvular heart disease. That table should be more than enough for you to answer all the valvular heart disease MCQs. I'll share it on the Telegram. Thank you. Good night, guys. Thank you.